meeting. If anybody wishes to object, please come off mic and say that you want to object, and we will stop the recording. Otherwise, we will move forward. It's nice to see everybody today. I have to disclose a couple of things first. One, I sound kind of funny, and I'm not like in the best of health. I came down with COVID this week, and I'm 3 days into it now. So 3 days into it, and just really enjoying it so much. And now I've spread it to other people in the house. So we've got happy people here. And also the division has an in-person meeting that starts halfway through this. So we will be losing Evelyn and Carrie and Lori and any of our DBH team that's here and not home sick. They will be leaving us around 9:30. This meeting was supposed to be dedicated to teasing through the directed payments for 2025, specifically the timely access triggers, so that we can make sure that we develop guidance that works for everybody across the 10 CMHCs. And we've had quite a bit of discussion so far. I was trying to find my notes about this because we last talked about this the third week of August, and then we were off for a couple of Fridays due to the holidays. So to the executive directors, did you make sure that these were the people you wanted for today's meeting here, your operational people? We're still good on that front?
Yeah.
Okay, great. Perfect. Thank you. All right, so let's just go ahead and open up. I think I received some information from some of you that was very helpful. Patricia, I think you sent some information about timely access with respect to the CCBHC language. And from the people that I've talked to within the department, we're all aligned with wanting to use that same definition for those cases that it would be applicable to, right? So timely access for the individual starts with the individual making contact with the CMHC or their guardian. Is that correct? It's everybody's understanding? Okay. So for the individuals who would make contact either directly themselves or through their guardian, does that work as the starting point for all of the other CMHCs, the ones that aren't immediately planning to become CCBHCs?
It will work for Riverbend.
Thank you, Cheryl.
I've got a question just relative to, and maybe Patricia can answer. In the open access model, when we were doing this and what we're looking at going back to, we're not taking a lot of information. Like we're not actually logging any information because that's what the protocol calls for. So I may call, but nobody's writing my name down. So is that my first contact, or is it when I actually show up? Because that's how the model works. That's how it's defined and prescribed to work, is you don't put a lot of effort into the front end. You wait till somebody actually walks through the door. So we're providing a time, but I don't know who's going to show up, and I don't necessarily know a name.
I can maybe field this if you want, Patricia.
Oh, sure. I was going to go right ahead, Jen. I mean, yeah, our process isn't quite that, Chris. We actually do try to get someone's name. So the first contact.
Right. So, but I think everybody's running that a little bit differently. So that's why I'm asking.
Yeah. So the CCBHC model is basically the first contact is the first time you actually speak with either, again, the patient or the guardian, and they're requesting services. And so you gather information about them, you do a preliminary triage and risk assessment, and then that moves over then to the next step, which is giving them times that they can come in and complete an initial evaluation. So that first time where you're talking to somebody and they're saying, I want to come in, I want to be seen, I've got X, Y, and Z going on, is your, in fact, first contact for CCBHC.
Okay. And when you
Jen.
do that, do you direct people towards eligible, non-eligible? Or is that just a triage step in your process?
Yeah, it's just, I mean, in terms of how we've created it, someone will be given those open access times. They come in, and it's at that point that we're assessing information and making a determination where they may go. So,
It's once they come in. I
Yep.
think the big thing is that the reason it's not as, I guess, simple as you just give people time is that the risk assessment issue really needs to be done. And so since you're asking some questions in that realm, you obviously gather their name and some demographics, not a lot. I mean, it's definitely a shorter process than we were doing before, to some extent, but it's still, you still really need to do the risk assessment piece.
yeah.
And is
And the
that
model,
part of the CCBHC
Yeah.
requirement?
Yes, yes. The model's pretty clear in respect to the fact that it's a referral that you may get from somebody is not first contact. So if you get a referral from a PCP or New Hampshire hospitals referring a person, it's when you actually make that connection to the individual, to gather again some of their information, do that preliminary screening. The one interesting piece is the model doesn't really define what a preliminary triage and risk assessment is. So it's very clear on what an initial evaluation is, what a comprehensive assessment is, but this piece, you kind of make it your own so it can be brief, but it really is that connection, and it doesn't start off with a referral. It's when you actually talk to them or their guardian.
Thank you.
So my question, Jen, is you keep referring to when you actually talk to them. So if somebody calls admissions and they get an answering machine because all the admissions people are on another line, and then we call back and we get their answering machine, does the clock start when there's a message left back and forth, or is it when you've actually connected?
When you've actually connected, because
Okay.
again, you have to do those steps of the screening. So, yep.
Thank you.
Yep.
So, other questions about if it's the individual or the guardian making the first contact? Does that seem to be the good starting point for the rest of the CMHCs? Because Chris, I recognize what you were saying about open access, and that's first appearance. So what we're trying to do is develop guidelines that will work across all 10 centers, regardless if it's CMHC or CCBHC. And on the open access, from what you described, it's first appearance. It's not the phone call.
So
Correct.
if someone is being referred from New Hampshire Hospital on discharge and, the social worker can call weeks ahead of time to get an intake appointment for when the person is discharged. When does the clock start ticking on that case? Because the appointment is set before the patient is discharged from the hospital. So is it 0 days of a wait because your first contact with them is when they come into the intake?
That was where I was going to go actually next, because we had this first issue about what timely access was from that from the person guardian, and then the other one is going to be from New Hampshire Hospital, a DRF, or from DOC, from the Community Reentry Program. So you're right there with us. I just want to make sure we finish the first piece of this so we can land in a good place. So
Diana, we have
ahead.
open access, just to say that there are people who might walk in. So we have that too, right? That they might hear that there are open access times from somebody in the emergency room, and they might walk in. So we have that capability as well. So it is a similar thing. They come in, they're requesting services. That's the point of first request.
Right.
I was
Right,
just
that
going to
makes
say,
sense to me.
so that would be a 0 wait. We'd have what we were going to refer to as a pre-admission date and then the admission date. Pre-admission is what we're going to refer to as when we actually have contact with the person, which is just our way to capture it in our system. And in that case, when they just walk in, the pre-admission date would be the same date as the admission date.
Okay. And Chris, where you had said with open access first appearance, so if that person calls, what are they told? Are they told just we have open access, just come by when you're ready or something like that?
Yeah, basically, I mean, to Patricia's point, we do, it sounds like probably even shorter screen than what Manchester's doing. And if there's somebody that's in need of urgent services, then we're on a different path, right? We're not on open access. We're either engaging emergency services or bringing them in, putting them in the system and giving an appointment. But otherwise, it's, they're given the times for open access.
Okay.
And they get to decide when they come in, if they come in.
So if we're giving times for open access, that's not going to count for first contact. It would be when they actually come in.
Well, this is what we're trying to sort through.
Yeah.
That's exactly what I'm trying to figure out.
We currently don't log information, right? So I wouldn't know. Like Jay, if you called, I wouldn't, unless you're in need of services now, you're going to have the dates and times of open access, but I'm not necessarily going to put you in the system at that point. When you actually show up is when I'd put you in the system. So I'd have no way to backtrack and pull a date that you initially contacted us.
So if you had, so you'd have to change your process if the decision today is that when I call you.
I would have to change my process.
Yeah. Okay.
But of course, my concern with that is I can't control when somebody shows up. If they show up a month and a half later, that's a month and a half later. And even though I gave them times as soon as possibly tomorrow, then I get dinged. So that's kind of the reason we're not loading up and taking, services and putting people in the system. Is the premise of this is to be as efficient as possible and not put your staff and everybody into that mode until somebody's actually there for services.
Yeah,
Chris,
I
what do
can
you-
see this
Oh,
this
go
measure
ahead.
working more when we controlled when we gave people appointments. In open access, the patient controls when they attend to the appointment, and
Right.
it seems backwards.
But Diana, if you could share, if you have the details on that payment algorithm, it might be helpful because historically some of your directed payments paid out like for eligible members, it was every eligible member that you had. But for other ones, it was there was a set aside of funds and the funds got distributed amongst the agencies that hit the mark. So let's say 3 of 10. And then the funds got distributed across the 3, either based on the percentage. If someone got 10% and someone got 50%, someone got 40%, that's how the funds were distributed. And so it wasn't really a matter about the ones that didn't achieve. It was about the numbers that did achieve. And if you have the details on how that payment works, it may be useful for people to understand that so they could shift their thinking to how the dollars get distributed ultimately.
Right. Great point. So on this particular timely access payment that we're looking at, there's no dinging if it doesn't, if you miss one case, there's no penalty to it. And for every successful one, meaning successful that the person got got an intake within 30 days of basically what we're looking at as first contact, then you are eligible for that directed payment. So it's not anything that would be punitive if you didn't get it. And Chris, I guess what I'm thinking about is when we look at your model right now, for that person that they might have called, and then it takes them a month and a half to come in, your timely access is going to start when they actually come in, right? Because right now you're not capturing any information from them. That's what you would be saying, right? You're not capturing any information, so whenever they come in is when they come in.
Well, that's what we're doing now. I guess the question is
Right.
that allowed to continue?
Well, okay, so let's tease through this a little bit more. What are your open access hours? Because it sounds like you have specific hours.
Different days, different hours, right? It's, so we offer some days in the morning and some days in the afternoon, because not everyone can do a morning and not everyone can do an afternoon. So,
Okay, so it's not, like 40 hours a week. It's not Monday through Friday, sort of normal business hours. Okay.
no, it's like a 10 to, a 10 to noon or 10 to 1, and then like a 1 to 3 or something like that.
Are people allowed to actually schedule an appointment or not at all?
So to Lori's comment, people coming out of the hospitals, we have appointments that we will give them. People calling, if you will, for an intake, would be given the days and times that they can come in. Then they decide what works for them.
So they still don't get an appointment even then. They get the windows.
They get the windows, right?
Okay. Any other sort of unusual approaches that we haven't talked about yet?
I
Or-
don't think
or
the
not
windows,
unusual?
I don't think the windows are unusual for open access. I think that every
That's why I
center
took
that,
it back, yeah.
Yeah.
Sorry. Anything,
Yeah,
any other operational details that are in some of the other CMHCs?
well, I just, to Chris's point and to Jay's point, once this initiative directed payment was rolled out, we changed our practice so that we would not, that now have a time that we would actually give the person and not just say, hey, here's the open access time, because you needed to have a start date. So I think it's important that we're all on the same page, that we actually have a first contact date. And not just that somebody has a window, because that way there, everybody would be meeting the metric.
Great. So Cheryl, you folks, if someone calls admissions, right, they get, you described phone tag. Does the clock start then, or when you actually have made that connection? So let's just say you've actually made the connection by phone, and do they get an appointment scheduled then or not?
The clock starts then. So
Oh, no,
that
I'm
we,
asking you, so oh, go ahead, sorry.
so the clock would stop then. And we would give them the open access time unless they asked for a specific appointment, and then we would accommodate them for a specific appointment. But we're recognizing that we have to make contact with the individual and not just, and take down the information, take down some identifying information, and to do a pre-screening, if you will. And then that's the initiation. That's the initial contact.
Okay.
So if they don't show up on those open access times, one of the things we've talked about is making sure that we outreach them and say, hey, you haven't shown up. Just wondering, how's things going? Do you still need to come in? Is there another time that would work for you? So that's one of the practice changes that we're implementing.
Okay. We have, we might have a little bit of language wiggle room, if you will, because we described it as application for services. And if you're not taking the information, if it's a phone call or something, and you're not taking any information about the person, then obviously it's not an application for services. But I do think that the intent is that when someone is trying to access services, that is them trying to apply to get services. We reviewed the rules, and Carrie, I think that Carrie and Eve, we had looked at the rules in terms of the application, and there's not really an explicit definition of what the application is in the rules. Is that correct?
Well, it defines an application as identifiable by name and a contact to get back to them. These are like the application shall be considered complete when it includes, and then the rule frames it out as basically identity and communication method as being sufficient to consider that a complete application.
Okay. That's helpful. All right. So Chris Kozak, it sounds like for your location, that's the one place that we're not seeing that first attempt at contact being recorded. The directed payment that we're looking at, the budget is approximately 1.2 million. It's $2,333.33 per event. If we do have it be that first phone call, that first contact, so it's uniform across all the 10 centers, is that something that you folks could operationalize there?
Yeah.
Okay. All right, so then it's the intake appointment. Before we move on to sort of that ending mark of that 30 days and that intake appointment, can we move forward now to talk about the scenarios with the New Hampshire Hospital DRF contacts? Because that's the next one. And now here is where it starts to get really a little bit different for the CCBHCs in particular, because I take it that you folks won't consider New Hampshire Hospital or DRF or Hampstead the individual or the guardian for that timely access to service measure. Correct. Okay.
Correct.
But you do have a mechanism to capture that you've received it, because you can capture it if it's the individual or the guardian themselves, right? So you have a way to capture if the receiving facility is making that contact.
Yes, it's a referral.
Yes, but the patient's not available for an appointment. Right? So it's difficult to hold us to a certain time frame when the patient is inpatient. So if there's going to be a point where the clock would start ticking, perhaps looking at discharge day,
Mm-hmm.
because then they're available for appointment. I don't know how the other centers feel about that.
Well, I think we've already all operationalized that to have an intake within 7 days from discharge, so it wouldn't be a change in our practice.
Mm-mm.
Agreed.
Jen and Heather, can you speak to this on Manchester's end?
Yeah, I mean, for me, that is a referral, right? So it doesn't really count as the clock starting. So I'm with kind of Cheryl, and I don't know how you feel, Jen, that we're already doing within the 7 days, that there's really just the clock starts when you see them.
Yes,
Yeah,
I agree.
I would argue those are two distinct pieces of data. One is referring to a referral has an operational definition of a referral, and the other one we've already operationally defined. So I don't know how you can combine those two into a single concept.
Yeah, I
I
agree.
think if we use the discharge date,
Well, technically, that patient isn't, outreaching you on a discharge date. So to me,
Yeah.
the referrals don't count in the CCBHC world. It's when
Mhm.
you're
And
first seeing the
then-
patient. So when they show up, that's your start.
Yeah, and
And
then
not
you're
just
now,
that, but you'd be duplicating the directed payment initiative for discharge date to appointment, because you're already giving a directed payment for being seen within 2 days after discharge.
right, and then
So-
by
We
adding,
intend.
They intend to stack them is what we were told. And that still could happen, but it's really when you're starting to count. And so I agree, if you haven't had any direct contact with the patient until they walk in for open access, then when they walk in for open access is your first contact.
Yeah, Lori's proposal is a great proposal, I think, but it is just that that's already a directed payment. The alternate is that we're not going to capture these people in this directed payment. We're going to capture them in the next directed payment, or we're going to capture them on the date that they come in. But for me, really, the thing is, I just hope that it puts all centers on the same footing and the opportunity to capture their directed payment on this.
So the
I
one
think
thing
there's a
is the same
nuance.
day, next day is not an intake. It's
Right.
any service.
It's any service.
But, well, any service covered by managed care, I should say. It doesn't include the crisis. And we know that some people could be getting those services, then the weekly follow-up services, and they may not be the full intake happening right away.
Right, every 7 days.
Yeah. And I don't know about others, but at least for us, a lot of times New Hampshire Hospital is having that person come or be seen before they're discharged. And so we're actually having that contact before they're even coming out.
Which currently we don't get paid for those intakes when they happen at New Hampshire Hospital. So I also think that I just want to say, I really don't want to measure this two different ways personally. One way for CCBHC and another way so that we can include this. If we go with the New Hampshire Hospital discharge date, we're somehow going to have to document that differently because it is not the same. It wouldn't be, we would be waiting until the person makes the contact. And so for us, it's really two different things. And I don't know if we're going in a direction. I feel like the more we align with some of the overall direction that people are going, the better.
So I think doing it the same as open access with our regular community patients, whereas when they come in, that is your first contact, and you could do the same with people coming from DRFs in New Hampshire Hospital. So you have 0 days wait for an intake.
Can you say that again, Lori? I'm sorry.
Sure. I mean, just like we talked about with someone calling and being given the times for open access, your day of contact is when they show up for open access. So you essentially have 0 days wait, because the day that they show up is the day they receive their treatment or their intake. New Hampshire Hospital or DRF discharges can be the same, whereas our first contact is going to be when they show up for their intake appointment. So it's 0 days of wait time.
I agree with you on that, Lori. I just want to reiterate for us that initial phone call would be the first contact because we're doing the triage risk assessment, right? So
Right.
even though
Same-
we're telling
same
them
for
to come in
Nashua.
tomorrow, it's still that first contact.
Yeah, that would be the same for Nashua. We're doing phone screenings with people. When they come in, they can either call and get a phone screening, or when they walk in, they get a screening. And so their intake then would either be the day they walk in immediately after their screening, their face-to-face screening, or whenever they came in after their phone screening, because we track those phone screenings, and that's a CCBHC requirement.
Right. So I think you're talking about like 3 different scenarios where someone calls, you're doing the screening, they come in, someone could walk off the street. That person might have 0 time, right? Because they didn't call you. And then other scenarios, right?
Chris?
2 things. One, Patricia went away. I kind of
She's
agree
coming
with
back in.
Patricia. We should pick how we're measuring this. I think having something for directed payment and then having a different vendor for CCBHC, and I just there's a lot of different ways of reporting. So I think there should be a consistent method of how this is being tracked and managed and reported. And then as we've been having this conversation and hearing how people are doing open access differently, I believe in our current contract, there is a same day or open access requirement, but it's not really defined as to what that is. And I think all the questions and things we're hearing here, either that needs to be defined in the contract or removed in the contract, given how this is proceeding with directed payments. So because things aren't aligning, 30 days is not in line with, just nothing is congruent anymore with it. So that has to be looked at.
So, and I just want to remind our group, for organizations that are CCBHCs, they do have to report this in line with the CCBHC metric, and the state does have to take on that data and report that data to CMS. So that will be happening. So organizations that are CCBHCs will be reporting it in that way. So that's just something to be thinking about and take into account.
Excuse me. I'm not hearing that there's a universal way to do this between those centers that have open access, those centers that will be CCBHCs. And I thank you, Chris, for noting about the contract language, because we can look at that. I mean, we're aware that starting this directed payment at 30 days was not consistent with some of the other requirements that we have for timely access to services. So the CCBHCs have 10 days, and then there's a requirement for seeing someone within 7 days. But what we were trying to do is use it to help infuse financial resources to help more people be able to get an intake within at least 30 days. And then, as you folks know, our plan would be to shift this to 20 days next year and then to 10 days in the final year. So sort of give the system the 3 years that CMS is giving us to get all of these services to 10 days. So that's, I understand it's inconsistent with what we have in the contract, but that's our logic there, was trying to infuse the resources to help staff the access to services. So, all right. I heard for the New Hampshire Hospital DRF discharges, looking at potentially the discharge date as the start of the clock, but then I also heard for the open access, wanting it to be the day they actually show up. For the CCBHCs, the first day the person calls. So it can't count on the CCBHC if it's the hospital making the call, correct?
Correct.
Right,
Right.
right. Okay. So again, I'm not sure we're going to get to an across the board methodology. At least I'm not hearing it.
I will retract the discharge date, because I agree with Patricia that the consistency is really important, so that we're not running different data sets to try to capture all of these different scenarios. So if it's the time or day of first contact, then it is the intake date that the person shows up after their discharge.
Okay, so where we have the same day, next day access, and that's something you folks have been doing for a long time. Same day, next day. Generally, we use quite a bit of that payment. We had to reconcile it up to use it all, but we were around like 80% or so in prior years. Oh, much less. What if we were to use that the day that same day, next day appointment, then you're meeting with the individual, right? And what if that's the start for the 30-day one? because you're making contact with the person.
Yeah, but can't, you just said that you can provide most services, right, except for crisis. For CCBHC, we're specifically looking at, the initial evaluation.
So you would be doing it the same day, next day? Heather, that's when you guys would do that?
Jen, can you speak to that?
I mean, I think I view same day, next day a little bit, I don't know, not view it different, but I think about it different. I don't think about it in terms of intake assessment necessarily, because that person may not come in same day, next day for intake post-discharge. Again, we try to give them, or they leave with something that's within that 7-day time frame, and then come in. So I see same day, next day for those established patients that we have that are coming in, that we're being, seen post-discharge. And a lot of times, again, for us, I don't know about others, but NHH on those newer folks are, especially if they're coming out on a conditional discharge, we're doing the intake while they're still there. And then they're discharged, and we do the same day, next day post that discharge date. So they're already connected with us.
And what they need same day, next day, post discharge isn't primarily going to be their intake. We're really trying to connect with people in the community and ensure they have what they need to be successful in that discharge moment.
Yeah, I'm not saying to do the intake at that same day, next day. I'm saying that for those that it is their first contact with the person. If you're making that same day, next day, it's your first contact. And is that an appropriate time to start the clock for the intake to happen within 30 days?
I would say yes.
And that would work for the CCBHC model, right? Because you're making contact with the person. Patricia, if you're talking, you're still on mute.
I mean, again, if it's a contact with somebody who's requesting services, then yes, it would meet that.
And doing the risk assessment.
Yeah.
and doing the risk assessment. Okay.
Yeah.
I'm trying to think of if we've sort of covered all scenarios here. So for those centers who have open access, do you still strive to do the same day, next day on a discharge? And would this work for you also if that same day, next start, the trigger for that one was also the trigger for the timely access?
Our discharges go through ES.
Would ES?
So they're I'm pretty sure meeting it. I don't have the data up, but I think it would be a similar process for us.
So your ES workers meet with them at discharge or within the same day, next day for discharge, right? But would they schedule like an intake for them at that point?
Yes.
Okay.
Maureen, can I just ask, is that even for your established patients?
It actually depends. Sometimes our established patients go through intake and sometimes they end up with an appointment with their provider. Like if they're ACT, they would go likely and just meet with their ACT provider. But if they've been disengaged from their team, they might go through ES. It's a little bit individualized, as it should be,
But they wouldn't be necessarily required to have an intake anyways, depending on duration of their inpatient stay, right?
I was thinking about the ACT clients because
Right,
I thought that's what we were. I mean, sorry, the new clients because I thought we were talking about intakes and
We are.
that intake. Okay, so
This one is expressly about intakes. Yeah.
Yeah, so someone who was a new client would go through ES, and they would have a contact with ES, and then they would set them up for an intake through generally through ES.
Okay.
Sometimes they might go to walk in, but it's more likely it's going to happen through ES.
So we're all 10 centers are very familiar with that same day, next day, directed payment. For those individuals that are discharging from New Hampshire Hospital or the DRFs, wouldn't it work then for us to use that appointment, that starting point, the same way for you folks? So the same day, next day is that clock starts at the discharge, right? Starts at the discharge. That goes back to Lori's original suggestion, potentially about starting it at the discharge. But because of the CCBHC model, it would be that first contact within 24 to 48 hours. That should be the start.
Correct.
That's right. Is anybody opposed to that? Okay. So if we did that, then
Diana, I'm
go
sorry.
ahead, Chris.
I don't know if I'm opposed to it. I want to go back to, I don't know if Patrick made the comment. I'm trying to understand it and reconcile it with the definition of referral versus contact. Right. So we started this with contact, which had to be the individual or their guardian. The DRF discharges are a whole different beast, because the hospital's contacting us, not the individual or guardian. And so now we've got two different definitions of contact, which is, I think, where my head is struggling, not with the premise of same day, next day, but who has to make contact for what situations, and where do I start my clock when? I think that's where my head's hurting.
So that's why we were looking at if the center had that within 24 to 48 hours post discharge, if you actually made contact with the person at that point, that potentially is what we're talking about being the start of the clock for the New Hampshire Hospital DRF discharges for the timely access.
Okay,
to
so
an
if we
intake.
made contact.
Right.
Okay.
Because then that works for the CCBHC model, et cetera. But then it also means that if we use that appointment, that first contact, the starting
But that's not a
point.
contact. The appointments, my concern is we're saying contact and appointment. The appointment is not contact. The appointment may or may not occur. If it occurs, there's contact. If it doesn't occur, there may be, another week or two in attempts to make contact before you make contact. So I'm going back to, what do we mean by contact?
And if I could just make the concrete point the way I'm looking at it, right? And I think Chris is also doing a really good job of explaining the discrepancy, right? You're talking about, actually now you're talking about three separate contacts, three separate actually operational definitions. But at the end of the day, you're only talking about first contact as being the definition of what you're going to base these things on, right? So what I'm basically saying is, you have a first contact date, whether or not they're discharged from the hospital or not. That date might or might not align, depending on some of the different scenarios. But we're not really talking about discharge being the thing that determines whether or not, the directed payment gets calculated that way. It's still first contact date, correct?
Correct.
So here's where the stacking comes in, right? Right now, you folks are familiar with the 24 to 48 hours, same day, next day. We'll just call it same day, next day, post discharge, right? So for that one, the clock starts at the discharge, and then you get the appointment in same day, next day. What I've got on the table here is that then for this second directed payment, the timely access to an intake, the ending clock for the same day, next day is when you're making your first contact with the patient, because you're actually seeing the person. That would be the start of the clock for them to get an intake appointment within 30 days after that.
But that contact may be one and the same. It may be a zero, right? And again, it's, I think we're still trying to blend the two. If the contact is when we actually contact them, and if that first contact happens to be within the same day, next day, and it happens to occur and it's an intake, right, then I think you're still in the same contact with the individual and it qualifies for the access directed payment because it's within 30 days. It happens to be
Right.
the actual same day.
Correct.
But
Right.
Correct.
I don't blend the two because my head hurts then. You have two separate directed payments, leave one as same day, next day, it occurs, it doesn't occur. The next one starts with contact and you get 30 days and it might be a 0 day if it happens in that window.
And
And I
the
just
point of
wanna-
first contact would be that follow-up, yes.
I know we're doing in the weeds of operationalizing, but I just want to remind people the idea with time to initial evaluation is the idea behind it is it's time from request for services by the individual. So we're trying to operationalize the request for services. That's how it's laid out in the CCBHC model. And that's, I think, what we should align with that general idea that we're trying to operationalize. I have to hop off, so I'll see y'all later.
Thanks, Mary.
So I can follow that, but I think it's the same question is,
But the way
what's
Chris
the request for
lined it
service?
Sorry, go
I'm
ahead.
sorry, Patricia.
No, I was just going to say, I think that the way that we lined it up, as long as you have the spirit of the fact that when that person comes in and they say, yes, I would like services, right? If say it's within that same day, next day, and they say, yes, I would like services, that's your indicator for first contact for the second measure. Because it is also true that someone might show up for that same day, next day appointment and say, no, thank you. I don't want anything more from you. I only came to this because it was a way for me to get out of the hospital. And so then you don't have a request for service. Right. So it really is driven in the way Mary said, is that it's the request for service. So if at that same day, next day, it may happen to be linked to the second measure, but it is only because the person says, I'd like to continue services.
Yeah.
Or I'd like services from you.
Yeah, thanks, Patricia. That was the distinction I was going to make. Similar to you, Maureen, if we have somebody who's coming out who's not established with us, we haven't done an intake before they got discharged, and they might be seen by our rapid response emergency service folks, and that same day, next day, same deal, right? Because there may be other circumstances where they're like, no, I'm going to go and get my treatment from LifeStance and I'm all set and good and thanks, and I'm a-okay. They're not requesting to continue on with us and to be established. So
Sorry, Jen, I was feverishly typing notes. Okay, so it sounds like using that follow-up appointment could work for those people discharging as the starting clock, because they're for the timely access to the intake. Because if the person says, no, I don't want an appointment, I don't want to carry on for services or whatever, then they're not going to get that intake appointment at all. But if they do say it, then you're seeing them in person. So it's actually the request for services, which is consistent with the CCBHC model. But the bad part about this, or the risk factor, is if the center doesn't actually end up connecting with that person same day or next day, which I think, Chris, was part of your concern.
Well, it wasn't a concern. They're separate measures, right? I mean, same day, next day is one metric and measure that we can get a directed payment on. If it takes 4 days to make that contact where they make their request, then you wouldn't get the one directed payment, but that starts your clock on the access payment, right? Because your contact with them actually happened 4 days later. It wasn't. That's what I'm saying. You can't blend these two. You might be able to double them up if it aligns that way, but I think they need to remain discrete measures, and be applied as such, so that you can have a consistent definition of request for service.
And in either scenario, point of first contact is point of first contact with the client or guardian.
Right. One of them, you may get both directed payments and one you may not, but you at least have a common definition.
Yeah, I think the department has a little bit of a concern on about the delay, particularly after the discharge. So if the center wasn't able to make that same day, next day appointment happen, or the patient wasn't available, right? Starting the clock to whatever time that person might outreach. I mean, the intent is we want the CMHC to make the connection with that person, right? So that's my only sort of side comment there. I'm not sure that that meets the intent. I mean, I know that it's a lot of money that we wanted to put into this, but we really wanted to make sure somebody had their intake within 30 days.
I mean, I'll speak for us. $2,300 is a pretty good incentive to make outreach and try and get the person in. But I think we need a common definition, because you're introducing another variable now, which is a post-discharge connection versus the initial measure, which is request to intake, which is 30 days. So we've just introduced a third metric or measure and making it even more confusing. I get the intent, but I think you've got a pretty good incentive for us to do the outreach if somebody doesn't come in, to try and get them in. But as I think we all know now, there's no guarantee somebody's going to come in. They agree to an appointment, they get their discharge, they go out the door. We're not going to hear from them. We can outreach all the time, but they're not going to come in.
Well, and as we discussed before, there's no penalty for that. It just isn't, potentially a win. That's all.
But right. But I just that's I think a reality we have to acknowledge.
Okay. I know that we're almost time and we haven't gotten into the DOC community reentry. I will tell you that the first contact will be coming through the MCO, I believe, to get the intake scheduled. In order to sort of think about what you folks have said about consistency with the individual, would the expectation be that the MCO, I don't think the MCO can have the person on the phone to request the intake appointment. I don't think that's going to be able to happen. And we talked about a two-step where the CMHC would start with delivering an appointment to the person pre-release through telehealth, and then finishing that appointment post-release. I know that was one of the things that we had talked about in the last meeting. We don't have enough time left for this meeting today. So what I would recommend is that we try to have the same people at the table for the next meeting, next Friday. And we pick up from that point of the discussion. Does that sound good to folks?
Yep.
Okay. And I did clarify that we do not need the warm case manager handoff part of the model. Is really, it's not necessary for it to be an actual case manager who is doing that appointment, that pre-release appointment. We don't really need the actual warm handoff case manager to happen. That was something they modified in the design over the past several months of working with CMS. So it doesn't have to be the case manager, but it could be the case manager. The codes that we're looking at is, which I'll need your folks' input on, is the 90791. But we also could do something with like 9920 something. So think about the who for that pre-release appointment, and then what kind of codes if it's a two-step process. And remember, the two-step process is needed because we can't have the directed payment trigger while they're pre-release. We need the directed payment to trigger once they're post-release. So we'll take that up next week. Sound good? All right. Thank you folks so much. Thank you for working through this. I know it's kind of gnarly to go through all of this, but I really appreciate your patience.
Feel better,
Thanks.
Diana.
Thank you.
Thanks.
Thanks.
Bye-bye.
Thank you.
Bye.